This program is brought to you by Emory University.
I was asked to introduce Dr. Woody Farrington. Woody was born and raised in Alabama. He went to college at Auburn and UAB and stayed at UAB for medical school and general surgery residency. He went to Cornell in New York City for his cardiothoracic surgery fellowship and completed an extra year of complex aortic surgery under Dr. Len Girardi, a very accomplished aortic surgeon. He came here to Emory in 2020. I've really enjoyed getting to know Woody, his wife Lauren, and their 4 young children who are all amazing athletes. He's a great dad, a terrific colleague, and a very, very talented technical surgeon. He'll be talking to us today about bicuspid aortic valve and associated aortopathy.
Thank you, Jeff. I appreciate the kind introduction, and I appreciate the opportunity to talk to you guys today. I selected for the topic bicuspid aortic valve morphology and aortopathy primarily because it's one near and dear to my heart, and maybe a topic that doesn't oftentimes get discussed in these type lectures. So I think we'll start out by just kind of going through some of the background of bicuspid aortic valve, morphology, classification systems. Why does some people develop bicuspid aortic valve as opposed to tricuspid aortic valves? What is the associated aortopathy? And then try to finish it off by how do I think about it as a surgeon when I see it in clinic. I'm going to try to limit the talk to 30 or 40 minutes and then have 10 or 15 minutes at the end for questions and try to get everybody out on time. Financial disclosures, I don't have anything relevant to disclose as pertains to this lecture. Bicuspid aortic valves, as we all know, it's an aortic valve. By definition, it contains only 2 cusps. The aortic valve controls the blood flow from the left ventricle to the aorta. And with discrepancies or abnormalities in the aortic valve, we can see hemodynamic flow changes across the valve, which can affect and lead to valvular complications, but also can create turbulences within the ascending aorta and aortic arch, which can ultimately lead to wall stress of the aorta and aneurysmal formation. Depending on which study you look at or which review article you look at, approximately 50% of patients with bicuspid aortic valve disease will undergo an operation or some sort of procedure for their aortic valve pathology throughout their lifetime. 25% of patients with bicuspid aortic valve disease will undergo an operation for some aortopathy at some point during their life, whether it's an isolated aortic surgery or a concomitant surgery with the valve procedure. Aortopathy in general is characterized by dilation of the aorta. And we think about this in 2 ways specifically, either aortic ectasia or aortic aneurysm. An aneurysm is classically defined as an enlargement of a blood vessel 1.5 times its normal diameter. So if we're thinking about ascending aorta, aortic arch, normal diameter is generally around 3 centimeters. So anything that's in that 4.2 to 4.5 centimeter range is technically classified as an aortic, ascending aortic or aortic arch aneurysm, aortic root aneurysm. Ectasia is generally just an enlargement of the aorta that doesn't meet criteria for aneurysm. Oftentimes we see these patients that are they may present as adults that are seeing cardiologist, their primary cardiologist or primary care physician in general with some element of symptoms. And oftentimes the first study we have are transthoracic echocardiograms, which make this diagnosis of a bicuspid aortic valve and potentially an associated aortopathy. But when we think strictly about the aortopathy in general, the gold standard for measuring adequate cross-sectional diameters for aorta is a CT scan or MRI of the chest. Aortic valve, bicuspid aortic valve disease is the most common congenital heart disease in adults. It affects approximately 1 to 2% of the population. It does have a male predominance of approximately 3 to 1, and it can present throughout life. We see patients that have been followed since a really young age in our clinic. We see patients oftentimes and most commonly that are diagnosed kind of in those middle age years, fourth, fifth decade of life. They presented with some element of symptoms and have undergone echocardiogram, which is diagnosed the bicuspid aortic valve disease. Just a quick schematic of what does a normal valve look like. Again, a normal valve is typically three cusp, trileaflet valve. Bicuspid valve, as you can see in the bottom of the picture, there is a bicuspid, so two cusp valve, where in this picture it's got fusion of the right and left leaflet. So how does this develop? Well, it's not entirely understood. There's some ideas. I think one of the original ideas was this idea of hemodynamic molding theory, and basically what that says, or what that tries to explain, is that a decreased blood flow through the valve during development results in failure of the leaflet separation. Now, there's not a whole lot of data to support this idea. It's limited, and the exact cause and mechanism of the embryologically development of the bicuspid aortic valve is fairly uncertain. There have been several studies that tried to pin down a better explanation for why and how the bicuspid aortic valves develop. One of those studies was published by Dr. Fernandez and colleagues. And basically what they did is they took mice and they knocked out this endothelium nitric oxide synthase chain to try to say, hey, is this something, is there some process or pathway going on at the endothelial level that causes these valves to develop abnormally? And the general kind of idea, or the general statements from that study, the conclusions from that study, showed that different bicuspid aortic valve morphologies were the result of different developmental processes. So in some of these mice, they developed bicuspid valves. Some of these valves were classified as type 0, type 1, type 2. Some of these valves were even tricuspid. So it's not really a clear one mechanism that causes bicuspid aortic valve development embryologically. Sands, Coma, and his colleagues, they took genetically similar mice and they looked at aortic valve morphologies, so same gene sequences, and they found within their study of the animals that there was a continuum of aortic valve morphologies. So in genetically similar mice, some developed tricuspid valves, some developed bicuspid valves. Classifications of the bicuspid valves were different in some of these mice. So that study drew the conclusion that factors other than genetics were also playing a role in the development of bicuspid aortic valve pathology. So exact cause and mechanism clearly uncertain. In 2007, Dr. Sievers and Schmidt wrote a paper. They evaluated 307 pathological specimens after surgery and during surgery with intraoperative pictures, and they tried to categorize these bicuspid valves based on morphologic appearance, their spatial orientation, and the degree of valve dysfunction. And what they did is they basically categorized it by the number of raphe that are involved. So in a Sievers classification of bicuspid aortic valves, you have a type 0, type 1, and type 2. Type 0, no raphe, so this is what we would refer to as a true bicuspid valve. Further characterizing these valves are spatial orientation. You can have it oriented in the lateral position or in the anterior posterior position. Again, these little circles on the valve in the subcategories indicate where the coronary ostia are located. In the type 0 valve, the majority of those valves, or more than half of those valves, were oriented in the lateral orientation. But as you can see, 4%, 2%, so a low number of these valves in total were true bicuspid valves, or what we think about as true bicuspid valves. Now, the most common type of bicuspid valve that we see, I think, in our clinics and in the operating room, are type 1 Sievers classification. And this is a single raphe defines these valves. So two cusp, a fusion of one of the commissures or one of the leaflets. And it can be incomplete or a complete fusion. Again, further categorized by where that raphe is located. We think about 1A as a left-right fusion, and by far the most common bicuspid aortic valve pathology that we see in our clinic and in the operating room. Makes up about 70% of bicuspid aortic valves, left-right fusion. And then non-right fusion, which will be fusion of this leaflet edge, is second most common, and then the non-left fusion. And then in a Sievers type 2, there's 2 fused raphe. Again, these are less common than the type 1s, but oftentimes these are associated with a high degree of aneurysmal formation, just due to what we think is due to the turbulence of the flow through the valve, and it can affect the root all the way up to the arch. If we're looking at strictly valvular competency, what they found is that a majority of these patients are going to have some stenotic element to their valve. A significant number are also going to have some sort of insufficient valve, and then there's going to be a mixture of both insufficiency and stenosis in quite a few patients. Very limited times that they find that there was no aortic valve malfunction associated with the bicuspid valve disease. So that's basically how we categorize it. We keep records of this in the operating room to try to understand this more. What Sievers classification was the valve, what was dilated, or specific classifications more common with ascending aortic pathology versus aortic root pathology versus aortic arch pathology. We'll get into some of that later. Again, this is just intraoperative pictures to try to better understand these Sievers classifications. Again, we have a Sievers type 0 with the lateral orientation. You can see the left coronary ostia is kind of hidden over here, and then the right coronary ostia. In general, this is pretty much a standard appearance of a bicuspid aortic valve that we operated on. Thickened leaflet edges, lots of calcium down at the base of the valve, and aortic annulus. This is a Sievers type 1, left-right fusion. Again, coronary ostia, normal commissures and leaflet edges, although you can see that the left-right leaflet edge is somewhat thickened. Not a whole lot of calcium. So this valve, appearance-wise, is something that we would think about potentially a valve repair, or if they had aneurysmal dilatation, some sort of valve preserving surgery. And then unfortunately, we don't see a whole, well, I guess fortunately, we don't see a whole lot of these, but unfortunately, this is generally what the type 1s will most of the time look like. Thickened leaflet edges, very heavily calcified leaflets, very heavy calcified annuluses. But again, this is a type 2. Again, 2 raphe, 1, 2, and then the bicuspid 2 functioning cusps. So bicuspid aortic valves often don't open correctly or do not open correctly, and the coaptation is oftentimes eccentric. We oftentimes see a lot of prolapse from a fused leaflet, which can cause eccentric flow through the valve. Together, these abnormalities produce an elliptical shaped orifice. Sometimes that orifice can be moved off center as opposed to a true tricuspid valve, where generally you have the flow straight through the center of the valve. And this can create flow disturbances and flow turbulences. And this is perhaps what leads to some of the early valve degeneration and calcification, and clinically significant aortic insufficiency and aortic stenosis. There have been several studies that have used transthoracic echocardiogram to look at bicuspid aortic valve pathology through time. And what those studies have shown is that cusp sclerosis, or thickening of the leaflet edges, generally begins in the second decade of life, and then there's progression of that over time, where calcification is prominent in the 4th and 5th decades of life. A study that was published about 10 years ago in the Journal of Cardiothoracic Surgery looked at pathological specimens. They took tricuspid valve leaflets and compared them to bicuspid valve leaflets. These leaflets had been resected for aortic stenosis in the setting of both tricuspid valves and bicuspid valve pathology. They analyzed both of these tissues with immunohistochemistry and PCR, and they found that a greater density of macrophages and more frequent neovascularization were seen in the bicuspid leaflets when compared to the tricuspid leaflets. So this kind of led to the idea that the pathogenesis of aortic valve stenosis and the bicuspid aortic valves were associated with more aggressive inflammatory processes, which led to earlier valve degeneration. Now, something that was also looked at and documented in the Sievers paper, but not often talked about, was the prevalence of aortopathy. So in addition to classifying, to coming up with a classification system for the bicuspid aortic valves, he also looked at the aortopathy associated with each type. And again, we can see that somewhere middle decades of life, around 20 to 25% of patients are going to have some sort of associated aortopathy that needs to be treated. And again, these type 2 Sievers bicuspid valves oftentimes will have root dilatation and ascending aortic dilatation. So type 2, a bad player when it comes to aortopathy, but a decent amount of patients, even with type 0 and type 1, had 25%, 1 in 4 ascending aortic pathology as well. So what does the aortopathy look like? So really 4 different flavors. We can have a bicuspid aortic valve with a normal aorta, so no aortopathy at all. Most commonly, we see this supracoronary dilatation. So the dilatation starts kind of just distal to the sinotubular junction, and most of the time it tapers off around the level of the innominate artery. It's more predominant oftentimes in this kind of what I refer to as the greater curve of the ascending aorta. And this is primarily due, what I think is primarily due to, oftentimes we have that left-right fusion. We get turbulences that are going to be projected in this kind of direction against that greater wall or that greater curvature of the ascending aorta. And this is going to lead to increased pressure, increased wall tension and dilation that is oftentimes not symmetrical. It's going to be more prominent on this wall of the aorta. We have what's called a Marfanoid type. Again, Marfan's patients typically have this appearance of a pear-shaped aortic root. We can see a similar finding in some of these bicuspid aortic valve pathologies where you get kind of a pear-shaped isolated aortic root aneurysm that doesn't necessarily affect the entire ascending aorta. It doesn't really affect the aortic arch. And then we can have a tubular type, which is basically dilation from the root all the way up through the arch. So what's the pathophysiology of the bicuspid aortic path aortopathy? I think in general, it's multifactorial. In general, it's studied, but it's not, there's not a one specific thing that leads to this aortopathy, but it's a combination of things. And I think, we've kind of hit on the hemodynamic turbulence and altered wall stress along different points of the aorta. I think that's one of the primary players. Obviously, when we read about any aortopathy, just regardless of the cause of the aortopathy, we always hear cystic medial degeneration, and cystic medial degeneration has been well documented in its association with bicuspid aortic valve pathology. As we remember back to anatomy, the aorta is made up of 3 walls: the intima, which is the endothelial layer, the inner surface of the aorta. Then we have the smooth muscle layer, which is kind of the architectural framework of the aorta. And then we have the adventitial layer on the outside, which is what we think about in surgery as the strength layer of the aorta. Well, this smooth muscle layer, it's got all these structural components that form a matrix that give it integrity. And one of those structural components is fibrillin-1. And we oftentimes think of fibrillin-1 in Marfan patients who have abnormal fibrillin-1 due to genetic alterations. Well, abnormal fibrillin-1 has also been identified in the bicuspid aortic valve pathology within the aortic valve, specifically the ascending aorta, and also in the pulmonary valve. So there's some spectrum of fibrillin-1 or lack of fibrillin-1 that leads to some of this aneurysmal dilatation within bicuspid aortic valves as well. Another pathway that's been well studied is this matrix metalloproteinases, and it's just like the name says, it's a proteinase that ultimately breaks down the structural architecture of this medial wall. So what happens is in bicuspid aortic valves, there's an increased activity of these proteinases, and they degenerate this intracellular matrix within the smooth muscle layer. When we think about genetics specifically for bicuspid aortic valves, we know that there are familial links that have been identified in bicuspid aortic valve disease, which may suggest an autosomal dominant type pattern with variable penetrance, but there's no specific gene that's been identified thus far as the root cause of bicuspid aortic valve pathology. Now, there is involvement in a specific gene called the Notch1 gene. It's been identified in a small population of bicuspid aortic valve patients, and these mutations in the Notch1 gene can lead to abnormalities in neural crest cell migration, which in embryology can explain the involvement of the ascending aorta, aortic root, and the bicuspid aortic valve. Because if we think back, those structures develop from the aortic sac, whereas the arch distal descending aorta develop from the fourth pharyngeal pouch and the dorsal aorta tube. So this might, some of these mutations may kind of give us some insight as to why is the bicuspid aortic valves, why do we oftentimes see bicuspid aortic valve pathology associated with root or ascending pathology and sparing of the arch and descending thoracic aorta. Another well-studied kind of potential effector of the bicuspid aortic valve development is this epigenetics. That's a whole different discussion. It's a research topic that's well beyond my scope of interpretation or understanding in some aspects. So I'm not going to hit on the epigenetics talk much, but that's something that is currently being studied as potentially a contributor. And then what we think about in normal cardiovascular disease, what role does age play in it? Is the patient diabetic, hypercholesterolemia, tobacco use, etc. So on average, the aortopathy associated with bicuspid aortic valve disease has a growth rate of about 0.5 to 2 millimeters per year. We know, pretty common that larger aortas grow faster as a rule of Laplace's law. So in general, a 4 to 4.5 centimeter aorta may grow at 0.5 centimeter to 2 millimeters, or 0.5 millimeter to 2 millimeters per year. But an aorta that's 6 centimeters in size is probably going to grow somewhere on a rate of 5 millimeters per year. So larger aortas grow faster. The historical thought was that the lifetime risk of aortic dissection in patients with bicuspid aortic valve aortopathy was around 6%. More recent studies have shown that that might be an overestimate. The most recent literature points at about a 0.1 per patient year of follow-up as the risk for dissection or rupture. And again, this is about 1 in 1,000 per patient years of follow-up. Dissection and rupture rates are higher than the general population in patients with bicuspid aortic valve aortopathy. Now, it's not patients that are dissecting at smaller sizes per se. When we look at different etiologies for aortic aneurysms and aortic dissection and rupture, the size range is comparable for when patients do experience these complications. So it's not, that they're dissecting or they're rupturing at a smaller size, but the higher rates than the general population of dissection and rupture are felt more likely to be related to the higher prevalence of aortic aneurysms and bicuspid aortic valve disease, also related to the rate of dilation and the younger age at the time of diagnosis. So patients being diagnosed with bicuspid aortic valve aortopathy at 40 years of age, as compared to maybe a sporadic aneurysm or atherosclerotic aneurysm where they're diagnosed in, the 7th or 8th decade of life. Now, this young patient with bicuspid aortic valve aortopathy has to live for 40 or 50 years with an aneurysm, as opposed to the other categories of patients who are less active at baseline and only have to live for 10 or 15 years with their aortic disease. So what do the guidelines say? So 2022 updated guidelines from the ACC and the AHA give class 1 indications for replacement of an aortic root or ascending aortic aneurysm at 5.5 centimeters. So this is sometimes confused with 5.0 centimeters because that's what a lot of the flow charts will say. But the class 1 indication for surgery on an ascending aorta or aortic root aneurysm is 5.5 centimeters. Now, class 2A indication are reasonable. We think it's reasonable to operate in patients with a cross-sectional area to height ratio that's larger than normal, or an aortic diameter of greater than 5 centimeters in a patient with a risk factor. And those risk factors are clearly defined in the updated guidelines. Those include a family history of dissection, rapid growth of the aneurysm, which is generally understood to be greater than 0.5 centimeter per year on surveillance imaging, coarctation of the aorta, patient with coarctation or family history of coarctation, that you can meet class 2 criteria for an operation to replace the aorta, or this quote unquote root phenotype. So what we showed earlier as the marfanoid phenotype or the root phenotype, that's that is a risk factor for dissection as well. Aortic diameters greater than 4.5 centimeters, we're generally going to treat those at the time of some concomitant surgery. So patient needs bypass surgery, have a bicuspid aortic valves working normally, but they have a 4.7 centimeter aneurysm. Majority of the time that aneurysm is going to get fixed at the time of their bypass surgery, regardless of if their aortic valve is pathology significant or not. And then kind of what we look at as the 5.0 without risk factors, it's reasonable to perform surgery in these patients. So really a class 2B recommendation if the patient's greater than 5 with no risk factors, and if they're a low risk patient. It's important to understand that the class 2A and class 2B recommendations have the caveat of patient needs multidisciplinary assessment, so it has to be seen by cardiac surgery and cardiologists, and we have to come to an agreement that yes, this patient needs an operation for X, Y, or Z reason. And also class 2A and class 2B recommendations are in centers of high volume aortic surgery. So that's classically defined, at least within the surgical literature, as aortic centers that do more than 40 operations for this specific problem in a year's time. So Emory meets that criteria. So in general, more than 5.5, we're always offering an operation, or most of the time we're offering an operation unless the patient's extremely high risk. Anywhere in that 5 to 5.5 centimeter range, it's an ongoing discussion. And then anyone that needs surgery for another reason, their aneurysm is greater than 4.5 centimeters, would generally replace the aorta at that time. So in patients that don't meet criteria, what do we tell them in clinic? How do we manage them? How do we go about it, and how do we think about it? Well, again, we want the systolic blood pressure somewhere in the 130 range or lower. We want the diastolic blood pressure somewhere 80 or 90 or lower. First line treatments are obviously beta blockers and or ARBs are our preferred antihypertensive medications. We always, assess for smoking history and discuss smoking cessation in active smokers. Statins should be considered based on the ACC and AHA recommendations. And then, one of the hard things is the lifting restrictions, particularly in these young patients that are active males that, may work in a job that requires them to lift, or, they may engage in, physical activity, weightlifting, etc. So generally what we'll tell them is try to limit the lifting to 75 pounds or less. If they need to do less weight, higher repetitions if they're going to the gym, that's something that we always discuss with them in clinic. But again, in these young males that are active, this is hard, and you can kind of gauge from the way that the conversation goes that oftentimes this is probably the one rule that's going to be broken, if not more than one. So we get a patient in clinic that doesn't need surgery, doesn't meet criteria for surgery. What are the recommendations for surveillance on these patients? So in general, anytime someone's diagnosed with a bicuspid aortic valve or some sort of associated aortopathy, the recommendations for a TTE at the time of diagnosis in all patients across the board. And this is to assess for aortic valve anatomy, function, diameters, and what's oftentimes forgotten about is evaluate for aortic coarctation, although this is very rare. If you're unable to accurately assess these 5 things on the transthoracic echocardiogram, then a CT or MRI is recommended. I'll say that my practice in general is, regardless of the quality of the transthoracic echocardiogram, I always like to get a CT scan just as kind of a baseline for a lot of these patients, because oftentimes we see them presenting maybe to an outside hospital 6, 7, 8 months later, who gets a CT scan. They call us over the phone. They say, hey, this patient came in with chest pain or shortness of breath, and we did a CT scan in the ER. He's got an ascending aorta of 4.6 centimeters. So I always like to have that reference point whenever I see someone initially in the clinic for their first time evaluation. And then the way that we typically will manage them in the surveillance clinic is once we get baseline, so day 0 initial clinic evaluation, we got a baseline scan. I will generally scan them again in 6 months. Oftentimes this relieves a lot of stress, particularly for the young patients with this new diagnosis. And it also reassures me that this aneurysm isn't growing at a fast rate and may cause problems in relation to the dissection of a rupture. So 6 or 12 months after the initial presentation is reasonable to get subsequent imaging. And then if that imaging is stable, typically what we'll do in our aortic surveillance clinic is we'll follow them yearly for a few years. Now, obviously, they're all young patients. If they're stable for 2-3 years, then we might stretch it out to instead of every year scan, every other year, or monitor them with echoes. Genetics evaluation is recommended for patients with bicuspid aortic valve disease and hereditary thoracic aortic disease, or phenotypes that are phenotypic features that are consistent with Loeys-Dietz, because we know Loeys-Dietz is a bad player, probably the worst player in aortic pathology. So medical genetics, we run a genetics lab, or we don't run a genetics lab, but we do genetic testing in our clinics for some of these patients, which oftentimes saves some time as opposed to having to get in and get seen by one of the genetics teams here at Emory, which sometimes can be 6-8 month wait times to get into those clinics. So what about first degree relatives? How do we screen them? What's the recommendation? So any patient presenting with a bicuspid aortic valve and an associated aortopathy, a class 1 indication is that all family members, first degree relatives, get screened with TTE. And if we're unable to adequately assess the valve morphology or aortic size on the TTE, then they need a CT or MRI. And this is bicuspid aortic valves with aortopathy, class 1 recommendation to screen first degree relatives. Now, if we think about bicuspid aortic valve disease without aortopathy, then that screening of family members is a 2A recommendation. So it's reasonable to evaluate those patients' family members with starting out with echo and then CT or MRI if needed. So 95% of the time it's not black and white, right? We see a patient in clinic and it's kind of personalized surgical decision making. I just included an example here, not uncommon. 51-year-old male, high functioning, normal life, wife, kids, goes to work every day, functioning member of society, presented to an ER or presented to his primary care doctor, shortness of breath on exertion. That's led to an echo. He's got a 50% EF. He's got moderate AI/AS, so mixed disease. And he's got an ascending aorta of 4.8 centimeters. So by the book, this really doesn't necessarily meet criteria per se for valve replacement or ascending aortic operation. But, you know, we're kind of in that gray zone where do we delay the inevitable? Why do we delay the inevitable? Patients oftentimes are saying, well, you know, you're telling me that it's eventually going to get to the point where I need surgery. Doesn't it make sense for me to have surgery at a younger age? So that's kind of a fine line we have to walk. And then they're asking, well, what's going to be the restrictions after surgery? And you tell them, well, you're not really going to have the same restrictions that you had prior to surgery. So they're at that point, hey, I'm low risk. I want surgery. Why can't we just go ahead and do it? So there's a fine line we kind of have to walk there. So we take into consideration the risk profile of the patient. Are they a high surgical risk? Are they a low surgical risk? That might influence us one way or the other. What is their occupation? What is their lifestyle? You know, are they traveling out of country for their job and going to third world places for months at a time? Sometimes that plays into it. You know, are they doing a lot of heavy strenuous activity at their job? Are they going to be limited by their occupation? So, and then kind of the final thing, or the most important thing that I generally think about is what about the valve? So, you know, are we going to be able to save the valve? Or are we going to have to replace the valve? Because replacing a valve in a 50-year-old is different than replacing a valve in a 70-year-old. So all these factors we're trying to kind of sort out or trying to investigate a little bit more in the clinic setting to try to make the best decision for each patient on an individualized manner. So what are the surgical options if they need surgery? So it can be as simple as normal or bicuspid aortic valve with normal functioning valve, but meets criteria for an aortic operation. Generally, just a tube valve. We don't wrap any of the aortas. I know historically that was kind of thought of as a treatment mechanism, but generally we'll cut the aorta out completely. So an artificial tube graft, both proximally and distally, and replace that piece of the aorta that's pathological. So native valve, ascending hemiarch replacement, aortic valve replacement, and an ascending replacement. We can have an aortic valve or a native aortic valve and a total arch replacement. This is a Bentall procedure where he's got root dilatation, so we can put in a bioprosthetic or a mechanical valve conduit. Again, the complexity of this operation is detaching these coronary arteries and reimplanting them. Are there some downstream effects from that? There always is a possibility of that when you alter the geometry of how these native coronaries lay. And then the kind of most, if we could perform this operation in every patient, it would probably be the best case scenario. Valve sparing aortic root replacement. You've replaced all the aneurysmal tissue, but at the same time, you've reimplanted their native aortic valve within that graft to prevent them from having to be on lifelong anticoagulation or have the lifespan of a bioprosthetic valve. So those are kind of the operations that we offer. It can be a combination of all these things. We can do valve sparing root, total arch if they've got that kind of tubular type dilatation we talked about earlier. What's not pictured here is a Ross procedure. Again, that's a different topic for a different day. I think that there is a certain set of patients that meet criteria or maybe good candidates for a Ross procedure. But again, that's an individualized approach. I can say that the Ross techniques are improving over time with respect to the allograft dilatation that was seen historically in those type operations. So I'm going to kind of end the lecture there. I'm going to tell you a little bit about the Aortic Center and kind of what we can offer and how we're willing to help. So there's 3 primary campuses, as we all know. The Aortic Center has aortic surgeons within the division at each campus. So at the Clifton Road campus, Brad Leschnauer's kind of our aortic expert over there. His clinic is run with the help of Alyssa Zellner, who's our nurse practitioner over there, and she runs an aortic clinic 5 days a week and sees surveillance patients 5 days a week over there with abilities to image in same day, essentially. Midtown, Brent Keeling does the majority of the aortic work at Midtown. We don't necessarily have an aortic surveillance clinic set up at Midtown, but we kind of siphon the patients off to either the EUH campus or the St. Joe's campus for long-term surveillance. At the St. Joe's campus, it's myself and Maria Traverso. Again, we have the capabilities of seeing patients usually within 1 to 2 weeks, 5 days a week, and have on-site imaging. The goal of the surveillance clinics is really to establish fast and accessible care for imaging and clinical surveillance. So we offer, generally we can get patients in to see us within 1 to 2 weeks time. So short notice, we're available. We offer a single clinic visit. Obviously, you know, if we can make it easier on the patients, they're more prone to getting their yearly scans. So we try to get the imaging done the day of the clinic appointment. And we have our nurse practitioners have guaranteed slots in the CT scanner to make this happen. So the patients tend to be agreeable to yearly scans. We don't lose out on a lot of patients that would otherwise say, you know, I don't want to go to the hospital 2 or 3 times or sit in Atlanta traffic. So we're able to capture a lot of patients that we may otherwise lose with this approach. We also have genetic testing. So we don't have genetic counselors in our clinics yet. That's something that we're looking to add in the next couple of years, but we can do quick buccal swabs or blood tests, and we generally will have the results back in 8 weeks for someone that we identify as potentially having a genetic issue. So with that comes our ability to also accumulate genetic data and use it to maybe guide some of these treatment algorithms and pathways in the future. And again, our providers that are kind of the backbone of these surveillance clinics are Alyssa Zellner and Maria Traverso, who work at the main campus and then at St. Joe's. I'll just include my contact information. If any of you have any questions after this talk or in the future, you know, want to say, hey, I got someone I want to run by you, I'm happy to talk to you anytime. You can call me on my cell phone. My clinic number is for directly to our scheduler, so you don't have to sit on the phone and go through all the automated stuff that you may have to do otherwise. And then feel free to reach out to me at any point in time with any questions. References for the talk, and then I'm happy to open it up for further discussion.
Great, thank you so much. That was fantastic and a very nice review. I don't know if anybody has any questions. If you could type them in the chat. I'll start off with one. You mentioned the genetic, testing. Who are you deciding to do that on? Is it because they have some other, aneurysms or some other reason, or is this for everybody? And then you mentioned the research. Sorry, two part to it. And then you mentioned the research side. So are you collecting that information somewhere?
Yeah, so that's a great question. So grand scope of things. Oftentimes these bicuspid aortic valve patients, particularly, their aortopathy is going to be related to that bicuspid valve disease. Sometimes, our general tendency is it's relatively cheap. The genetic testing is relatively cheap. Insurance covers most of it. The maximum out-of-pocket payment for our patients is $200, and most of them will agree to pay that regardless of if insurance pays or not. So we're pretty aggressive on our genetic testing just because we think that one, it can do a couple things. It's probably not gonna, it may or may not change the treatment algorithm for the patient, but it might give us some indicators as to how would it affect first degree family members. So I would say that majority of the dissections that we're seeing, at least within the last 4 years that I've been here, a lot of these patients are young, middle-aged. We often see dissections in 70, 80-year-old, but a lot of these patients are younger than 65. So anyone that's younger than 65, we've kind of come up with the general consensus, hey, we should probably genetic test all these patients. So phenotypic appearance, family history, those are kind of things that lead us into, hey, should we genetic test them or not? The company that we use is called GeneDx. It's a buccal swab in the clinic. We send it off through FedEx. They get the results in 6 to 8 weeks. But the great thing about the company that we use is we don't have to go in on the back end and upload all the data into spreadsheets. They keep it categorized. We have our own account from the Aortic Center. So all the patients that have ever been tested through GeneX are accumulated into this account that we can log into. We can search by patient. It shows us all their mutations. A lot of times variants that have some sort of unknown significance at this point in time. That's generally the way that we track the genetic abnormalities in the patients. It's kind of all automated.
Great, great. Thank you. Okay, so there are some questions in the chat. There's a question from Alex Sommerfield. After aortic valve replacement without need for aortic surgery, how common do you see patients go on to develop aortic aneurysm and need for surgery?
Yeah, that's a great question, Alex. And you would think, you know, with all the flow turbulences and flow disruptions that we see, you would think, hey, if we fix the valve, then the aorta should stop growing, but that's not the case. And that's some of the evidence that's led to this investigation on what's happening at that kind of smooth muscle layer. You know, these patients, regardless of the valve being corrected, or the flows being normalized, they still have some underlying pathology going on in that medial layer of the aorta and degradation of the structural framework. So we can, from time to time, we'll see patients that have had an AVR for bicuspid pathology, have not had an aortic operation, that have developed aneurysms over subsequent 10 to 15 years. And we kind of make it a point to keep all these patients best we can within our surveillance scope. That way they're getting scanned on a routine basis and we can intervene in a timely manner because an elective surgery carries about a 10 times lower risk of complication as opposed to an aortic emergency.
Thank you. There's a comment from Maria Traverso. She's happy to take referrals directly to her cell phone, and there's her cell phone, and I'll leave that here so that you can screenshot it, 404-360-9041. Thank you, Maria. Kritan Ramatis has a question. After ascending aortic replacement, do you routinely screen the tube graft or the rest of the aorta, and how often?
We do. So generally the post-operative kind of treatment algorithm that we follow is we'll see the patients 3 or 4 weeks after surgery with a chest x-ray, make sure they're doing well, recovering okay, or as anticipated. And then we generally will see them 6 months from the date of their surgery with a CT scan of the chest. And then we'll follow that out yearly for the first 2 to 3 years. If everything remains stable, then they need to be followed on a routine basis throughout the rest of their life. So generally we'll stretch it out to every other year. The majority of these patients are going to have ascending or aortic root pathology, sometimes proximal arch pathology. So we try to correct all of that at the time of the initial surgery. But regardless of how much aorta we have to take out at the initial surgery, the downstream aorta or the distal arch, descending thoracic aorta, still carries about a 10% chance of aneurysmal dilatation over the lifetime of the patient. So it is important to not only screen them prior to surgery, but also continue to survey them after surgery to look obviously for issues with, surgery itself. You can form pseudoaneurysms, suture lines, et cetera. So we want to make sure that we identify those early, but also that downstream aorta can be affected long term. So we generally screen them after surgery, and that's kind of our algorithm.
So when you first have the CT of the chest, right, and you've got, let's say, a 4.5 that you're going to be monitoring in clinic, do you do abdomen and pelvic? Do you do the whole every 6 to 12 months?
I like to get chest, abdomen, and pelvis at least at baseline. So say I see a patient that comes in as a referral that has a 4.5 centimeter aneurysm, maybe mild, moderate aortic insufficiency, bicuspid valve, and it's someone that we know we're going to be screening for probably the next several years at least. I like to get a chest, abdomen, and pelvis just to make sure I got a picture of the whole aorta. Now that might be at the initial evaluation, or it might be at the 6th month. If they come in with a CT chest, then I don't want to give them all the contrast and radiation back to back. So I might say, hey, at your 6-month appointment, when we look at this ascending aorta again to make sure it's not growing, we're going to get chest, abdomen, and pelvis at that time. But subsequent scans, as long as the abdominal and the descending thoracic aorta, abdomen, and pelvis are normal, subsequent scans will go back to a just CT scan of the chest. We also prefer, it's easier for us to interpret the images if these scans are EKG gated. So with the EKG gated scans, we get less disturbances or less motion artifact from the ascending aorta if they're timed appropriately. So that's generally what we'll follow them with long term, is EKG gated CT scan of the chest, assuming they have no other aortic pathology.
Great, thank you. Andy Smith has a comment, a very informative talk. Reminder that Tyrone David from Toronto will be speaking Thursday at EUH Auditorium at 7 a.m.
Yeah, that'll be a very informative talk, and Dr. David's probably forgotten more about aortic disease than I've known so far. So he's a pioneer in the field of aortic surgery, and will be a very informative talk. So I encourage everyone that can make it to try to attend that discussion.
Hey, it's Peter Block. Can I ask a quick question?
Yes, absolutely.
Lovely talk, lovely review. I want to talk or ask you a little about aortic regurgitation and how that affects this. Couple of questions. Number one, a lot of these bicuspid valves, particularly if they present in younger patients, have aortic regurgitation as their primary problem. Number one, do you think that kind of patient who has primarily got AR with a lot of anterior flow, which then comes back down, is more prone to have their aortas change over time, even after you repair them? And then the second question is, what about aortic repair in a patient who has primarily AR? I recognize that's a completely different topic, but nonetheless, Cleveland Clinic used to think about doing that in the 2000s, and I don't know whether or not they are still doing it. Is it reasonable to do that in a young patient, or can you not repair them adequately and just go ahead and fix them?
No, I think it's a very, very good question. And so I think that aortic repair, if we could repair everyone and get a good, durable, long-term outcome, I think that would be the gold standard. Now, the aortic valve repair is obviously more technically challenging than, say, a mitral valve repair, just because you're limited in your leaflet tissue. But I think that aortic valve repair for a young patient with bicuspid aortic valve disease is a possibility, and I think that it's something that we should entertain if able. Now, there's some nuances to it. Obviously, a lot of times we see that if it's a fused leaflet, we see that fused leaflet or that raphe is a little thickened or calcified even in young patients. And what happens is that fused leaflet prolapses to cause the regurgitation. So our goal in the surgery is to get that coaptation height or that coaptation location centralized to the middle of the aorta, because oftentimes it can be off to one side or the other. And also to get the length of that free edge, the margin of that free edge, and the height of that free edge consistent across the coaptation plane. So there's a couple different mechanisms that we can use to repair it, to raise that leaflet height in the fused. We can debride the raphe of calcium. We can plicate the leaflet edge. We can plicate the commissures. So yes, there are ways to do it that are reliable, so to speak. And I think that you know, it's something that we should entertain, probably more so than not. Now, the downside to that, or the alternative to that, is you have a patient that's got maybe, say, mild, moderate AI, young patient, but they're willing to take a mechanical valve. So then you're in kind of the conundrum of, okay, is this repair going to be durable, or is a mechanical valve going to be more durable than this repair? Knowing that, you know, we're going to have to put them on anticoagulation. So that's kind of what goes through my mind when I'm thinking about young patients that we could potentially spare the valve and do an aortic valve repair or a reimplantation technique with an aortic root operation. So that's kind of how I think about it. And I think that, yes, you still see, to answer the first part of your question, I think that, yes, you will see some, especially in young patients, you will see some continued aneurysmal growth. If, you know, say they're 4.0 centimeters at the time of surgery and you don't address that aneurysm, I think the likelihood over the next 40, 50, 60 years of that patient's lifetime is that you're probably going to see some aneurysmal dilatation. I'm fairly aggressive with the aortas, especially if I'm doing an operation for some other pathology, aortic valve, whatnot. I know the guidelines say 4.5 centimeters, but if a patient's 4.3 centimeters and it doesn't have a whole lot of risk to the surgery and they're young and otherwise healthy, they're probably going to have that aorta replaced at the same time. At least that's my kind of thought process and the way I approach it.
All right. Thank you so much. And really wonderful talk. And thank you for the time this morning. And thank you also for keeping us right on time.
All right.
We appreciate that.
Reach out to me with any questions, email, phone. I'm happy to, you know, talk about anything.
Great. Thank you.
All right. Thank you.
The preceding program is copyrighted by Emory University.